Hi, I'm Dr. Brian Haas, the National Medical Director at Ascend Hospice. Today we're talking about heart failure in hospice care, specifically how to document it accurately so that your care stands up to CMS scrutiny. Too often, hospice teams deliver outstanding bedside care, but struggle when it comes to document it in a way Medicare accepts. And when we're talking about heart failure, the challenge grows. Unlike cancer or neurologic disease, heart failure doesn't always show a straight line decline. It waxes and wanes, which makes audit risk even higher. So what we're going to do is we're going to break it down step by step. So Medicare's local coverage determinations, the LCDs, are our roadmap. For heart failure, they break down into two big buckets. Of course, we have our general decline criteria, but then we also have disease-specific heart failure criteria. And here's what CMS expects to see for heart failure patients. They want to know that this is a New York Heart Association Class 4 patient that has symptoms at baseline, fatigue, dyspnea, and angina at rest. And most importantly, they need to have symptoms that are refractory to optimal medical therapy. Objective evidence of decline, like multiple hospital visits, declining ejection fraction, or an inability to tolerate medications due to hypotension or renal failure. Functional or nutritional decline, a weight loss of more than 10% over 6 months, albumin of less than 2.5, or a PPS score below 50%. Comorbidities that make things worse, diabetes, renal disease, COPD, or dementia. Now remember, not every single element must be present, but the more that are clearly documented, the stronger your case. So here's where things often go wrong. If you don't mention the New York Heart Association class, even if symptoms are severe, if you don't say class 4, CMS doesn't assume it. No EF is documented. Heart failure cases without a recent or historical EF are at high risk of denial. No mention of decline. If your recertification note looks like your initial cert note, CMS assumes the patient is stable. No hospitalization or exacerbation data. These events show instability, but if they're not documented, CMS won't count them. No PPS or weight loss trends. You may observe decline daily, but Medicare wants it spelled out in numbers. These gaps are what trigger audits, denials, and eventually disenrollment. So let's do a case example. So an initial note may look like something like patient with CHF, chronic shortness of breath, increased edema, and poor appetite. That's a pretty weak note, not a lot there. But so why would CMS deny the claim? Well, we didn't say the New York Heart Association class. We didn't mention the ejection fraction. We didn't mention the PPS. We didn't mention the objective decline. Now, if we used a tool like Hospice Intelligence, we might improve our narrative. We might get something more along the lines of Mr. X is a 79-year-old with a New York Heart Association class 4 heart failure with an EF of 20%, presenting with severe shortness of breath at rest, orthopnea, and fatigue with minimal exertion. He's had 3 hospitalizations in the past 5 months. Recent labs show an albumin of 2.3 and a PPS is 40%. He's unable to tolerate diuretic therapy due to hypotension. Continued hospice care is appropriate. I might even extend this a little bit further to say, what is the minimal exertion? He's no longer able to transfer. Is he a 1-person assist or a 2-person assist? So there's lots that we could continue to do and expand. One tells a story and one meets the standard. So why does this matter? Denials hurt more than revenue. They delay the patient care. They force teams into reactive appeals. Of course, they frustrate your families and they demoralize your nurses. Hospice work is already difficult. We shouldn't have to fight audits on top of it, but the best defense isn't legal, it's clinical clarity. So how do you reduce your audit risk? Know your LCDs. If you don't already know your LCDs, using a tool like Hospice Intelligence that's going to take your documentation and compare it against the LCDs and offer you up alternative selections will be your best bet. Be specific with function scores. Track weight loss and albumin. Mention ejection fraction in New York Heart Association class. Compare notes over time. Not just recertify, but recertify the decline. Now remember, Medicare doesn't deny care. It denies documentation. When we capture the full story, we give our patients what they deserve, uninterrupted, dignified care. Thanks for watching, and if this was helpful, please like and share, and as always, advocate boldly, document clearly, and care compassionately.